So to summarize, when we're doing our initial chest x-ray evaluation, we want to make sure it's the right patient's name, the correct date. We're going to look at the projection, position, and orientation, and then evaluate the quality of the film, the adequacy, rotation, degree of inspiration, and then exposure and penetration. And then we're going to go through the ABCs of X-ray interpretation. As mentioned, airway, bones, cardiac silhouette, and mediastinum. Evaluate the diaphragm, edges, lung fields, gastric bubble, the hilar structures, any invasive devices, and finally, the soft tissues. And now I'd like Dr. Stevens to kind of put this all together. So we've listed these elements here, and we're going to evaluate each of these on this particular X-ray.
So name and date we've had to crop off for privacy issues. You want to make sure it's a PA or an AP film, and you can see in this patient that the scapulae projecting a little bit over the lung fields, and usually if a patient is supine, it's always going to be an AP chest x-ray, which can give you a false impression of the heart size. You want to make sure that the patient is well centered, so you can see the spinous processes relatively equidistant from the medial end of the margin. You can see the vertebral bodies, may not be able to see them in great detail, but again you can also appreciate the bones, and we can see that they're covering the lateral margins of the ribs. You can clearly see the first rib. So that's a good film. It's adequate penetration, the patient's not rotated. The patient is intubated, so it's sometimes difficult to get a really good inspiratory film in these patients. So, we can only see probably 3 anterior ribs, so it's not adequate from the inspiratory point of view, but the other things are relatively good in this patient. So we're going to go through the ABC. So initially we're going to look at the airways. The first thing to notice that we have an endotracheal tube in there, and the tip of the tube is probably about 2 centimetres above the carina, which is correct, and we can see the right and the left main stem bronchus. We're then going to go and look at the bones, and you can see that the patient has a fracture of their distal clavicle on this side, and we also have some irregularity of the ribs here. So you can see that they probably have some rib fractures here as well. You can also see behind the heart, and you can see that the vertebral bodies appear square. There's no obvious compression deformity. Next thing we'll go to look at is the cardiac silhouette. It does look somewhat wide, but it's important to remember that the patient is supine, and they've also got a poor inspiration. So, that can give you a false impression of both cardiac enlargement and widening of the superior mediastinum. When we're looking at the diaphragm, you can see the contour of the left hemidiaphragm very nicely. When we look at the right hemidiaphragm, it appears somewhat elevated and a little bit irregular. So the patient may have a degree of atelectasis or collapse, which is responsible for that. We're going to look around the margins of the film just to check that the patient doesn't have either a pneumothorax or a pleural effusion. When we look here, we certainly have got some soft tissue thickening, but that may be contusion from the adjacent rib fractures. We'll follow the margin round. We're not seeing a particularly deep costophrenic sulcus here, but I would be suspicious in a patient with rib fractures to make sure they don't have a pneumothorax. The lung field, lungs are not particularly well expanded. There's a little area of opacification here, which again perhaps could represent a small lung contusion. We want to see a gas bubble, but in this patient they have a nasogastric tube down which may have decompressed the stomach, and also it's not an erect film, so you may not necessarily see a large stomach bubble. The hilum, again, slightly difficult to appreciate in this patient, probably are a little bit rotated, but we can see the left main pulmonary artery and you can see the right main pulmonary artery. Invasive devices, we've already talked about the satisfactory position of the endotracheal tube, and you can see the nasogastric tube. You can't see the tip of it on the film, but it's clearly below the left hemidiaphragm. You want to look where the tip is as well as the side port, because sometimes the tip can just be in the stomach and the side port is within the distal esophagus, which is not optimal. We also want to look at the adjacent soft tissues, and you can see that the patient has fairly marked subcutaneous emphysema, which is extending up into the neck here. So again, very suspicious for the rib fractures that the patient may also have a pneumothorax on this side.
Fantastic, and you can see how many abnormalities were detected by using a systematic approach, the ABCs, to the evaluation of this particular chest X-ray. This has been part 5 of how to read a chest radiograph. I really want to thank our expert, Dr. Kate Stevens, for her insightful commentary on all of our chest X-rays, and we hope that you've learned a lot about evaluating chest radiographs. Thank you.